May I now call upon Professor Kamani Vanigazuriya and Dr. Upul Disanayaka to conduct the next session on diabetic foot disease.
Good afternoon. Good afternoon. Welcome you to the next guest lecture on diabetic foot disease. And it is my pleasant duty to introduce the speaker, Professor Devaka Fernando, MD, FR, CP, MSc, consultant in endocrinology, diabetes and general internal medicine, and honorary professor, Sherwood Forest Hospitals, NHS Foundation Trust, Sutton in Ashfield, Nottinghamshire, United Kingdom. Over to you, Dave.
Thank you to the council and the academic group for inviting me. The diabetic foot, for some reason, is always held after lunch, and you'll probably find out why as we go along. So what I would like to do is to ask some questions and try to answer those questions, because it's a healthy thing to question existing knowledge, and we know for a long time that people with diabetes absolutely fear the loss of a limb, an amputation. And if you do surveys, they often say that's the one they fear most. So what I'd like to do is to define the diabetic foot, to try and understand the underlying pathology, to look at risk stratification of these people, be able to classify an ulcer once it occurs, and of course, to be able to manage a person with a foot problem. So it's all about measuring the weight of evidence, but I borrowed this slide from the President of the Royal College of Physicians, because this is exactly what we do when we manage a person with a diabetic foot. It is exercising that skill of judgment. So I'll briefly go through some of the evidence, but I'd like to talk more on the yellow sphere about how we exercise clinical judgment, and I'll touch on where patients' values and preferences may be there. So the fact that diabetic foot disease is not inevitable, everybody with diabetes doesn't get it, and that's been known since the 1930s. So it's basically defined by the WHO through a rather complicated definition. I like my old boss's definition, Professor Andrew Bolton's definition, much better. Any foot pathology that results directly from diabetes or its long-term complications. So if somebody steps into on a thorn, or if somebody drops something on the foot and they get a massive gash, that's technically not a diabetic foot disorder. So how common is it? Well, you can see that it's very, very common. And the problem of it being common is that there is a cost to it. So if you look at mortality and post-amputation mortality, that adds further. There was this study from Sri Lanka from a decade or so ago, which actually quantified diabetic foot ulceration in Sri Lanka. It's a rather modest cost compared to what the UK spends on it, but it's still quite expensive. And this slide from the World Diabetes Federation tells you how common it is. So every 20 seconds, somewhere in the world, somebody loses a leg due to the complications of diabetes. It's that common, every 20 seconds. But unfortunately, it's a neglected area. So it's given a place in most conferences, but when you actually practice medicine, you find that the diabetic foot doesn't actually get the weight of importance that it should be given. So it might be that it's nobody's business. So they end up on a general surgical ward or a general medical ward. So this seems to be a very appropriate forum to talk about management of the diabetic foot. So it's not a very glamorous field, and it's not everybody's cup of tea. So why do people get ulcers? Well, they get them because of circulatory problems, nerve damage, mechanical stresses, and so on. So how do these things work together? As you can see, the ulcers occur on plantar surfaces. If there is a deformity, the natural shock absorbing mechanisms aren't working and they can get ulceration. So it's basically a pressure ulcer. There's nothing magical about it. People can't feel it. They stand on it. If you and I stand for a long time, we get the sensation our feet are killing us, we go and sit down. A person with diabetes doesn't. They could stand on something, warm sand, for instance, walking on the beach could result in burns. And of course, they can have deformities. And these deformities disrupt the pressure mechanisms and they can get ulcerated. They also have damage to their muscles. They get wasting of the small muscles. And if there is nerve damage in a limb, the natural response is clawing of the toes. We know all about clawing of the fingers, because that's taught to every undergraduate, but peripheral neuropathy results in a clawing of the toes, and it creates this pressure point at the apex of the toe. So you'd expect ulceration there. So ulcers do occur at the apexes of those clawed toes. And then the metatarsal heads become prominent because of the clawing. So you get an ulcer at the metatarsal head because there are abnormal pressures due to the neuropathy and they are vulnerable to it. So this alters the foot biomechanics. It alters the characteristics of weight bearing. People with diabetes often have limited joint mobility. So every MD candidate knows about Rosenblum sign. And the same thing happens in the feet. So they can get these deformities. Now these can be treated with appropriate footwear, and you can make a mold of the foot, and you can reduce all these stresses by offloading. Now what of sensory neuropathy? Well, sensory neuropathy, as I explained, results in loss of protective sensation, and it can be different types of neuropathy. And both large and small fibers are lost. And it need not be symmetrical. It can be an asymmetrical or patchy neuropathy. And as you can see, the metatarsal heads are the target area. So the mechanisms of ulceration, as I mentioned, was it could be just a glass or a stone or something in your foot, in your shoe. Most of us would know there's a pebble in the shoe. People with sensory neuropathy don't. Repetitive stress is the other mechanism. As I said, the mechanisms are there. It's a recipe for disaster if you got neuropathy. And of course, if you got diabetes and if you got neuropathy, wearing one of these is absolutely lethal. Now, when I was a young man, men also used to wear platform shoes. This was in the 1970s, but now we don't see that. Only the ladies wear them. So we see an disproportionate number of foot ulcerations in people with type 1 diabetes, younger women with neuropathy, mainly because they've got to go out on the town in the weekend. They might have a bit of alcohol, that dulls the sensation further, and they come in with a foot ulcer. Of course, when the nerves are damaged, it damages the autonomic nerves as well. So this means the skin isn't lubricated. So it's a premature aging, actually. The skin becomes brittle, it becomes dry, there are cracks, and all these are a portal for bacteria, and they can get infected. So increased blood flow to the skin through arteriovenous shunts makes the skin warm. But actually, it's not perfused because it's just passing through, it's not going through the capillaries. So that makes the skin more vulnerable to ulceration. But a neuropathic foot is warm, and that's an important physical sign. They also have prominent dorsal veins that do not collapse if you elevate the foot. And that's another physical sign in neuropathy. And PACES candidates and MD candidates, when asked to examine the lower limb in this person with diabetes, would have to go through this drill. The other mechanism, of course, is vascular disease, and this is incredibly common, more common in people with diabetes than in people without. And you can see the statistics there. So remember that this occurs in every part of the arterial tree. So a person, arteriopathic diabetes is not just the foot, it's the coronaries, it's the gut, it's also the carotids. So they are equally at risk for those. Now the interesting thing is, if somebody comes with an ST elevation myocardial infarction, you don't call the diabetologist. You refer them to the cardiologist for a percutaneous intervention. If somebody comes with a stroke in that golden period, you don't call the diabetologist because they've got diabetes. They go and have a thrombolysis. But if you get somebody with gangrene of the foot, the first person that they call in the UK is the diabetologist. Now that doesn't sound right because it's a foot attack, just the way the stroke is a brain attack and the myocardial infarction is a heart attack. So feeling the pulses obviously is the very important part of the assessment. So feel the pulses, check for nerves is the best way to manage these feet properly, and you can work it out from there as I'll show you. Whoops, what happened there? Sorry, I seem to have lost the slides. Can I just click this one? Can you get that down to beyond those slides, please? Keep going. Okay, so if the arteries do get blocked, obviously you know all this stuff, this is very basic undergraduate stuff, but how does this translate into the clinical features? The ulcers, unlike the neuropathic ulcers, are painful. The neuropathic ulcers, because they are long-standing, will have lots of callus. The ulcers will be at the most vulnerable areas for ischemia, which are at the ends of the extremities. And there will be trophic features like pallor and hair loss. And these are some of the appearances. So the diagnosis of an ischemic limb is visual and palpating the pulses. You don't need a fancy test to do this. And these show some of the typical sites of damage, combinations of ischemia. Sometimes it's just a simple thing like a bandage. And vulnerable pressures, this is just, again, something from a bandage. Somebody just dressed a wound, and then you end up with gangrene. And that is the final end result, tissue loss, gangrene, which becomes demarcated, and then later it becomes dry, and that's called mummification. And hopefully it will stop there, and that will dry off and drop off, but not always, unfortunately. So the question is, it can spread pretty rapidly, and this is an example of how rapidly it can spread in just a short time. So the initial assessment, again, is clinical, just the general appearance, visually inspect for trophic features, deformities, check the pulses, check sensation. So how do you do that? Well, you look at the ulcer, for instance, measure it, because the measure of width as well as depth is important. So this is just a summary of how you distinguish between these two. It's classic undergraduate stuff. The P's, the painful, pulseless, pale foot. So I haven't actually talked about investigations at all, because this is a clinical diagnosis. You don't need a Doppler to diagnose it at this stage. And of course, neuroischemia can occur together. But the primary cause for the ulceration, or the correctable cause, will be the ischemic component, because that's what causes the gangrene. And so referral to vascular surgeon becomes very important in these situations. Ideally, sensory testing should be pressure perception threshold, because that's what causes the ulcer, the pressure. So it's far better to check this than the pinprick or the vibration or the joint position. And it's a very simple test that you can do for that. Equally, another simple test for circulation is Berger's test. It's basically testing the foot circulation against gravity. If it becomes pale when it goes up and it becomes red when it goes down. Now, vascular surgeons use ABPI, ankle brachial pressure index, but the problem with people with diabetes is that they've got calcified arteries. So a reduced ABPI has a good predictive value. But if it's normal, or even better than normal, beware of calcium in the blood vessel walls. That's making the changes. If the nerve damage is prolonged, as with all neuropathies, there could be a neuroarthropathic change. The characteristic feature of this is, of course, the deformity, and that's the Charcot foot. The treatment of that would be to support it during the critical period, and you use that with offloading. I'm not going to really talk about the theories of Charcot's and the immunological theories and the mechanical theories. Basically, it's there. We don't understand what happens properly, but you can treat it by preventing further damage. So you can either use a total contact cast, which is the bottom one, or you can use a removable cast, which is the inflatable boot. So if the patient ends up in a general medical ward or comes to the OPD, the question is, are we going to send this patient to the medical ward, the vascular surgical people, or to orthopedic surgery? So this evaluation is important. So this is what we've been talking about. Neuropathic or vascular, how deep is it? Is there infection? How do we assess depth? Well, the University of Texas scan score is the very useful one. So is it skin? Is it deeper than that? Or is it going to bone? So if we do that, we can classify them in this classification. So the best place to be is in the top left-hand corner. The worst place to be is in the bottom right-hand corner. So if the pulses are palpable, they are either A or B. If the pulses are palpable and there is no infection, they are A. And then you classify it on depth. If the pulses are not palpable, they are C or D. If the pulses are not palpable and there is infection, it's got to be D. So how does this help us? Well, if they are, for instance, A3, your friendly local podiatrist and orthotist could sort it. If they're in B3, you'll need the microbiologist for the antibiotics, put them on IV antibiotics, and if necessary, call the orthopedic surgeon to remove infected bone. If they're in D, you definitely need the services of a vascular surgeon. So if you do a clinical assessment and you can put them in, you know where to send the patient. So with surgical input, these are the areas that you might need a surgeon. If there's a deep abscess in somebody who's been on oral antibiotics or IV antibiotics, and then you think, hang on, this is not getting better, shall we remove the dead bone? Or if there's gangrene. And of course, if it's ischemic, in that critical limb ischemia period, they can be revascularized. Even later, you can save a limb if you can't save a toe. So I think this is important that we refer to vascular surgery immediately, because there is a golden period just like with a stroke or an MI. So vascular surgeons can revascularize and save limbs if sent early enough. So tissue loss is like your 2 millimeters of ST elevation. Tissue loss is like focal neurological changes. Treat it the same way. Get the vascular guys in and you can save limbs. But if you can't, you can hope that there'll be demarcation, mummification, and dry gangrene, because that doesn't spread. Wet gangrene will spread. So referral is important, and this shows what can happen. And this is a patient who was admitted, and this happened because it was over a weekend and there was no vascular cover over the weekend. Can happen even in the UK. So with foot infections, I'll quickly go through the foot infections. You can have deep abscesses, and they are often refractory to medical treatment, so they're going to need a surgeon. So you get the surgeon to come in and deal with it. Infection in the person with diabetes sometimes isn't that obvious for these reasons. And you can see that some of the wounds can just get trapped and they can burst through. And there are many reasons for that happening. So in very simple terms, it is a clinical diagnosis, it is a generalist role. In places where you can have a multidisciplinary team, there'll be a team supporting you of podiatrists, specialist nurses, and others who can do this for you. But for the district general hospital in the UK, it is actually the general medical ward that deals with this, or the emergency practitioner. So I'll stop there, and if we have time for questions, I'm quite happy to answer them.
Sorry, sir, we don't have time for questions. And may I get my co-chair, Professor Kamani Vanigasuriya, to hand over the certificates of appreciation.
Thank you very much.